occlusion. When it's going to be a trauma, the first thing you have to evaluate is the bone, because in cases of trauma, most of the alveolar bone would be, there's a possibility it can be lost, or any root fragments are be present there. So you have to evaluate the bone. Second thing is caries. Apical pathology is possible. So now, if you are going to place an implant, if there is going to be any kind of existing pathology there, apical pathology, you can end up in a peri-implantitis. Third is periodontal disease. How to evaluate the periodontal disease in a clinical practice? Very simple. Ask the patient what is having any change of taste in the morning. நிறைய பேஷண்ட் சொல்லுவாங்க, சார் காலையில் நினச்சி வாய் ஒரு டேஸ்ட்டாக ஒரு மாதிரி கசப்பாக இருக்குது சார், வாஷ் பண்ண அப்புறம் தான் ஐ ஃபீல் பெட்டர். This is one line we have to very carefully observe. If there's going to be some change in taste and the patient gets back to normal only after brushing or rinsing the mouth, definitely there is some kind of discharge is happening in the mouth. It is a clear sign of active periodontitis. And obviously the clinical examination follows this. But this is the first indicating line. Traumatic occlusion. Observe the occlusion. That is most important. Everything starts with occlusion. Everything starts with occlusion and then the restoration and then the implant. So you have to observe the occlusion, rectify any traumatic occlusion. You can do enameloplasty or you can go for finer orthodontics. Eliminate the traumatic occlusion before you place the implant. Clinical examination, extraoral examination, go for the lip profiles, any kind of abnormalities or any kind of abnormal positioning of the lips, especially in secondary patients where they are given some bulky patients. We can see the upper lip will be more prominent. So all this has to be documented. And obviously intraoral examination. The first thing I look out for in intraoral examination is halitosis. Xerostomia. So in patients having xerostomia, they will definitely going to attract lots of plaque. You have to check the salivary secretion. If the salivary secretion is not okay, there's going to be deficient salivary secretion, you have to treat it first. Never ever go for an implant in a patient with xerostomia. So it attracts lots of plaque. Maintenance is very difficult. Eventually, very easily there is possibilities of failures. And obviously then followed by periodontal evaluation, looking out for caries, soft tissue evaluation. All this comes with intraoral examination. And once you complete all this, then the imaging starts. Then your intraoral periapical radiographs or the CBCT evaluation. So all this imaging comes only in the last. So it doesn't mean a patient walks in, I have seen many clinic, I'm sorry to say, the first thing they write is get the CT done, then get a CBCT done. Definitely not. Please don't go for that. And finally, once everything is clear, when the patient is going in for an implant, we can then go in for your diagnostic and waxers. So once these are all, the evaluation is clear and you are going for the next level, you have to look in for the lip line and the smile line. So lip line refers only to your upper lip. So how much of hard tissue and soft tissue, the dentate tissue as well as the gingival tissue is being exposed during the smile. We have to record it. At times we can even take a photograph, a mild smile, moderate smile and an extreme smile. We have to record this in 3 stages. Make sure how much of the teeth and gingiva is being reflected. We have this classification: high lip line, the average lip line and the low lip line. High lip line is one of the most challenging because you have to aesthetically please, you have to work both on soft tissue as well as the restoration. Whereas in average lip line, you can still work on the restoration. It doesn't mean you have to compromise, but if not, the primary focus can be brought down a little bit. And low lip line, you're all in the safe hands. So the next will be restorative space analysis. So either we can, today we do this in a virtual way, but previously we used to do it with a diagnostic model. What do? We measure the dimensions of the adjacent teeth and replicate in the edentulous area. The mesiodistal dimension, buccolingual dimension, apicocoronal dimension of the neighboring teeth, it should be at par with the edentulous space. If it does not, we have to modify the edentulous space or else we might end up in micro or macro processes. So once this planning is done, it can also reveal us whether how much of interdental papilla we need to regenerate. Then comes the biotype, far most important. There are only 2 biotypes. One is a thick biotype, we call this a phenotype also. The thick biotype or a thin biotap. The gingiva thickness is more than 2 mm is thick. It's a heaven's paradise to work with this biotap. But in case of thin biotap, it's going to be a little nightmare because you have to place the implant little more palatally so that it will not impair with the prognosis of the aesthetic prognosis of the processes. How do we check for biotap? Very simple. Take a simple periodontal probe. Don't go for a regular probe. A periodontal probe, it should be blunt. Insert it under the gingiva. If there is no blanching, the gingiva it remains as it is. It's a thick biotap. But the gingiva blanches. That means the tissue is being stretched. Only when very thin tissues will get stretched, and it is considered a thin biotap. So what are the complications? The first thing, when you place the implant labially or when the biotap is very thin, the first thing is you will see the black shadow. Can you see this black shadow here? Because this, so in the pink uniformity you will find a black shadow. So that's the first indication you have missed something. The first thing you do is explant graft, send the patient. Because if it's going to stay there, you are still more to complicate the issue. What happens is with the bone remodeling, there are more chances the implant will get exposed. And of course, the patients are very meticulous about this. They observe the smile and some kind of difference they get back immediately. And once it osseodegrades, it's going to be very difficult to regenerate. So, what is the deadliest combo? The deadliest combo is highly blind with a thin biotap. It doesn't mean that we can't do implants in such case. We take a little help from our periodontist, fellow periodontist, before as well as focus on the planning part before and during placing the implants. So then we come to imaging. The first we go in for an intraoral periapical radiograph. What do we see in the intraoral periapical radiograph? We see the surgical space. Similar to a prosthetic space or restorative space evaluation, we do something called as the surgical space evaluation. See, this case looks prosthetically very comfortable. But look at the intraoral periapical radiograph. Their roots are literally tapering towards each other, right? So, what will happen when I place an implant? Look at the space. It is triangular. It is triangular with the apex towards the apex of the roots. You have to correct these orthodontically. See, this is how you evaluate. The base is wider and the apex is smaller. So this is how you evaluate with the periapical radiograph. If this is a sign, you have to first correct this and then go for the implant. So what will happen if I place the implant here? Definitely it's going to hit the neighboring teeth. The same thing with this. Okay. So what is the ideal? It has to be parallel or divergent. So either parallel or divergent. The apex should be divergent. So once it is, you can confidently place your implant and go for your restoration. And then CBCT. So the entire bone anatomy will be evaluated in this. So what to look for? How to evaluate the CBCT? The first basic thing is Professor Scott Gans. In 1995, he gave this concept, but till today this is in trend. So when you are looking at the cross-sectional image, first thing you have to do is, imaginarily you have to draw a triangle with the apex of the triangle in the crest of the ridge and the basal triangle towards the nasal floor. Okay. So, and we have two arms connecting the apex and the base. So the anterior arm represents the labial bone, the basal arm refers to the basal bone, and the posterior arm refers to the palatal bone. So your implant should always start from the apex of the triangle and end in the mid-basal arm of the basal arm. The midpoint of the basal arm. Can you see this here? This is the midpoint of the basal arm. This should be the apex of the implant, and the platform of the implant is towards the apex of the triangle. This is the first indication you have to observe. Second thing is, draw an imaginary line along the anterior border of the bone. So compare it with take the deepest point and compare it with the anterior arm. Measure the space. If that space between the labial surface and the anterior arm is 2 mm, you can blindly go in for an implant placement. If it is 2 to 4 mm, it needs grafting. You have to graft and place the implant in the single stage. And if it is more than 4 mm, you have to graft, wait for it to settle down at least for 3 to 4 months, and then you have to go for an implant in stage 2, and then the process is in stage 3. So this is the very easiest way to evaluate. You can just look at the CBCT, imaginally draw a triangle and take the call how your process is going to go. So once you decided to go in for the implant, what are the basic things we have to evaluate is 3 dimensions. So epicoronal dimension, mesiodistal dimension, and the faciolingual dimensions has to be evaluated. So epicoronal dimension. So where I am going to place the implant in the epicoronal relationship. So this is going to be the ideal placement. So what is going to be my ideal placement? It is going to be 2 mm above the CE junction of the neighboring tooth. That is where my platform of the implant should be. It shouldn't be below this, it shouldn't be above that. So you have to be very, very clear where you are going to stop the platform of the implant. So this is the ideal position. But in this case, the ideal position is far below. What happens here? Look at the processes. Can you look at the frontal elevation? Aesthetically it will appear very feasible, but will the patient will be able to maintain this? Definitely not. There will be lots of foot locking. Eventually the patient will lose the facial bone with time. So it's a big no. And again, we are increasing the depth. This is the platform of the implant right now, and this is going to be the ideal position. That is 2 mm above the C junction. See how much you have sunk the implant inside. Look at the height of the processes. Will this be aesthetically acceptable? Absolutely not. And even if you try to increase the length of the abutment and then go for the process, you are going to end up in a vertical cantilever. So this is one such case. So there was a huge bone loss. Practically speaking, you are supposed to remove this tooth, you are supposed to graft and then place the implant, but unfortunately implant has been spaced. Look at the length of the processes. Literally equivalent to the length of the implant. So what's going to happen? All forces will end up in the platform or on the abutment screw. This, especially for this implant, there's more possibility of abutment screw fracture. So it's a big no for this kind of cases. The faciolingual or the buccolingual placement. See, in this case, the implant has been placed more palatally. So I'm going to retain my deliver my process. What is it? It's going to be a faciolingual cantilever. This is how my process is going to occur. So what will happen when the patient bites here? It's going to be this portion, especially where the process is connected to the implant. There's going to be exorbitant forces. Again, there's a possibility of breakage of abutment screws. Now I place the implant more labially. What happens? By the time I fix the process, my screw axis of the implant or the abutment channel ends up labially. Again, it's going to be an aesthetic compromise. So where should I place my implant? Very simple. Connect an imaginary line between the cingulum of your 2 adjacent teeth. An imaginary arc connecting the cingulum of the 2 adjacent teeth. And there comes your position of the implant. So when placed in such a way, the implant axis goes exactly through and through the cingulum, fulfilling biomechanics and aesthetics. So this is how we have to calculate that faciolingual portion. So what happens if I were to place the implant more labially? Similar to the thin biotype and labially placing, the similar complications do occur. So either my implant will get exposed with time, or to compromise it, I have to give a very bulky processes. Again, this is one of the failure cases referred to me. What happened is one lip was inside, one side of the lip was inside, the other side of the lip was outside. So that's definitely the extra-oral examination. We found this. It's unacceptable. Either the process you have to make is very bulky. Again, it's going to be a challenge, or the screw axis ends up labial. So all these three cannot be compromised. The mesial-distal placement, obviously with the next adjacent teeth, it should be at least 2 mm away, and between two implants it should be 3 mm space between these adjacent implants. Why? Not to impinge on the anatomical structures, as well as for a better emergence profile. So these are all mesial-distal complications. You can see when this mesial-distal is complicated, the adjacent tooth, the life of adjacent tooth is gone, your implants can't be restored, and at the same time you will not get an ideal soft tissue emergence. So this is going to be your ideal position of implant for anterior teeth. What is this? This is in the mesial distal. The distance between the teeth should be 1.5 mm or more from the CEJ, and the central incisor is to note the incisor foramen. Always don't go more towards this. The faciopalatal 1.5 mm of bone should be at least available in the facial aspect, or 0.5 of the bone on the palatal aspect, 0.5 to 1 mm. These are all the minimum values. The angulations, it should be always in the behind the incisal edge. It should be always in the cingulum area, and the depth, it shouldn't be at least 2 mm below the CE junction, and it shouldn't be more or less. So now coming to the pink aesthetics or gingival aesthetics, we call this the gingival emergence. So when you are planning an emergence, we have to plan the emergence in 3 different areas. The first thing is the facial emergence. The second thing is the interproximal emergence. And the third one will be the palatal emergence. So you have to work on it individually. So how I'm going to deliver an emergence? First thing is I have to go for after placing an implant, we generally be going for a temporary or a transitional abutment. Add more composites to it. Very slowly build up. You insert it, call the patient after 2 or 3 days, again add some more composite, insert it. So the gingiva will slowly contour. So these temporary abutments are available in plastics or even in titanium. So once you start building this emergence, we call this the critical and the subcritical areas. With composites, you will be able to get your desired emergence. So how should I plan this emergence? In net you can find Dr. Alberto Miceli. We call this the umbrella concept. It's a concavo-convex pattern. See this? It is a concave and then a convex pattern. This is for the facial aspect. Again, interproximal, it is going to be a concave and a convex, and a less prominent on the palatal aspect. Are you able to see this? Yes. So this is what we follow in adding these composites. You can even get the article. It is umbrella concept by Professor Alberto Miceli. So once you are clear with your provisions and your soft tissue, everything is contoured, you can plan your processes and you can plan your abutments. So abutments for anterior zones, we get multiple array of abutments. We have a zirconia abutment, we have peak abutment, we have titanium abutments in multiple angulations based on your position of your implants. But the in thing today is no abutment implant processes. So what we do is we make the abutment and the process as one single component in the lab. So all we have to do is either we can screw the process, we can screw the it is one single process. We just have to screw it with the implant, and that finishes the job. So very slowly the transition is making from a cement retain process to a screw retain processes. So impressions, mostly for a single tooth implants, we going for a closed tray technique. There are 2 basic techniques. One is the closed tray technique and an open tray technique. Wherever multiple implants are there, you are supposed to go for an open tray technique. Whenever there is a single tooth, we can go in for a closed tray technique. So how we do it? This is a closed tray impression coping. We connect it with 20 newtons torque. Once it's connected, seal the apex with wax. Now make an impression very similar to AFPD, either with a polyether or addition silicone. Once it's made, you can remove the impression coping and place the healing cap. and you connect the impression coping with your lab analog and insert it in the impression, and then you put the model, and then you can make a model. So once the model is ready, it's going to be an exact replica of what is in the bony cavity. So in the lab, what they do is they connect the abutments, they customize the abutments based on the requirements of the case, and then they make the processes with the list of requirements what you have given. And with that, what you have to do, we place the abutment. This is a cement retained case. Once you fix it with the luting cement, you lute the crown. So this is going to be your final process. This is the protocol for a closed chain impression. So we have a case for anteriors. It's a 21-year-old boy who lost his upper central right accident. See, he wanted a new teeth with aesthetic smile. This is one requirement. Requirement number 2. His previous teeth was proclaimed. That is one of the reasons he hit the ground in the primary impact. So he wants his new teeth in alignment. Now this is going to be the challenge. See how, look at have you recorded the requirement of the patient? If I would have placed the implant without listening to this, even my implants would have been proclaimed. Then I would have gone on with the existing profile. So my thought is I have to bring the profiles more inside. How much inside? So that was the planning part. So this is the preoperative status. So this is the OPG. So we planned. So we brought the implant by 2 to 2.5 mm. We brought it palatally and placed it with a punch. We didn't open up the flap. And moreover, we prepared the neighboring teeth also accordingly to take up the processes. This is the temporization. We gave an immediate temporization. Look at the temporary. This is a milled polymethyl methacrylate. So gone are the days like we used to do the flasking for heat cure acrylates. No, when we see this is the requirements, in the lab they design it in the ExoCAD, and the entire PMMA is being milled out from a PMMA block, and your temps are ready. Maximum 10-15 minutes your temps are ready. All they have to do is polish, send it back to your lab. Maximum within 2 hours I'll fix my temps. So we can see even after bringing the teeth with the alignment palatally, I still have my access openings in the cingulum area. Yeah, can you see this? So this is possible only with planning. Look at the gingival emergence which has been created by the umbrella concept. Can you see this? The ethnic contour, and the biotype was excellent. Even since I have worn more palatally, I had ample soft tissue. So after 3 months of healing, we went for stage 2. We scanned and we digitally designed the processes. And this is going to be my final processes. You can now look at the overjet, overbite. Look at the profile. This is the post-op. So we usually record this in 3 stages: mild smile, moderate smile, and extensive smile. This is an average lip line. It's not a high lip line, it's not a low lip line, it's an average lip line. Exactly, that is 25% of the gingival side of the tooth is been covered by the upper lip. And the patient is pretty much happy with this. This is the post-operative OPG. So we started from here. This is the planning part, and this was the final process. One concept is, wherever I used to discuss this case, the first thing they ask, sir, neighboring பக்கத்துல 2 பல்ல தேய்ச்சிட்டீங்க, பேசாம ஒரு bridge போட்டு வேலையை முடிச்சிருக்காங்க சார். Why you want to trim the neighboring tooth? Why you want to digitally plan and spend and all these things? Ladies and gentlemen, look at the age of the patient. 21 years. If suppose I would have gone for the bridge, momentarily I would have been very happy. In 1 week's time I would have finished. But after a decade, what would have happened? Look at the amount, imagine the amount of hard and soft tissue recession would have happened. People are wearing FPDs, when they remove their bridges after a long time, practitioner would have definitely observed there would have been a huge dehiscence of a hard tissue. There would be a huge envelope. And that time, after a decade, when the patient wants to go in for an implant, He has to graft soft tissue, hard tissue, and it's going to be an extensively material, very a complicated procedure, I would say. So by placing an implant, I am preventing the bone loss as well as the soft tissue loss in the long run, literally throughout the life of the patient, if it has been done properly and it's been maintained properly also. Okay, so there's no need to feel bad when you're going to trim your neighboring teeth and again you're going to give an implant. There's nothing to feel bad. Actually, you're doing good to the patient in the long run aspect. So now coming to the posteriors. So the main requirement will the patient will be giving is to chew comfortably. So again, when you are going for osseointegration, clinic aesthetics and restoration, the patient's entire focus is only on restoration, but you are supposed to give all these three. So again, the restorative space analysis, which we have discussed this before, the BC-distal buccal evaluation as well as the epicocoronal evaluation. This evaluation is very important because this evaluation decides what kind of process you are going to go for. Either it's going to be a screw retained process or it's going to be a cement rated process. See, restorative space should be at least 8 to 12 mm. The minimum we will have is 5 mm. Okay. Up to 5 to 8 mm or up to 10 mm we can go in for a screw retained process. From 8 to 12 mm we can go in for a cement rated process. Cement rated process requires lots of vertical space. Why? Because the size of the abutment, the metal coping as well as the ceramic coping and one layer for the cement. So look at the amount of hardware needed. Whereas in going for a screw retain, all you need is a metal coping and the ceramic in it. The no abutment protocol which I discussed before. So all you have to do is place it and screw it. So when the vertical space is compromised, always go for screw retain. Literally in my point of view, I do only screw retain in my practice. Why? Because retrievability. Anytime I want to retrieve the implant, retrieve the processes, I can just unscrew, remove, do the maintenance, fix it back, tighten it, happily send the patient. If I would have done a screw retain, the only way for me to retrieve the process, cut the process. And if the process comes out, I am happy, but my cutting will damage the abutment. Then patient will ask for free abutment. So look at the amount of complications. Okay. And intraoperable radicals. So before going for a CBCT, always take an IOPA. Look at the bone. Look at the homogeneity of the bone. Look out for any root pieces, any kind of localized bone loss or localized abscesses. Look at all this. Go in for a uniformity. If you find it is uniform and the volume is ample by clinical examination, then you go in for a CBCT. If the first slide is going to be revealed in IOPA, I'm going to stop my planning in that stage, allow it to heal for another 1 or 2 months and then go for a repeat IOPA and then plan for the CBCT. So again, prosthetic challenge, if a tooth is migrated towards each other, build up the restorative space first because you have placed your implant successfully but now your process is now going to be compromised. And your IOPA also gives an idea of whether to go or not for a sinus lift. You are not going to plan this whether your sinus lift, whether it needs or not. If it needs, then you have to go in for a CBCT. So again for a CBCT, the same concept, the diagnostic triangle we discussed before, and the triangle is made and then the dimensions of the implant and the angulation of the implant, everything is being planned. One most important thing, especially in mandibular posteriors, very, very important, but most of clinicians miss is the parapharyngeal spaces. See, this will not be revealed in an IOPA, will be revealed only in a CBCT. At times the entire parapharyngeal space will be slightly more bigger. It can alter the entire curvature of the bone. The entire bone will be C-shaped. So at that time you are going to drill your cortex in the occlusal portion as well as the lingual portion also. What can happen? The implant will have an excellent stability because it is sitting on 2 cortexes. Bicortical anchorage we would say. But what is the minus? There is this bleeding here will be in the oral cavity. But what about the bleeding here? That blood will slowly accumulate in your parapharyngeal space. Patient will come with a swelling in the base. It can even lead to Ludwig's angina, compression of the airway, the first thing you have to do is admit the patient in the hospital. And if it is mild, you are okay. If it is very severe,